issues and topics that are very relevant at the local level. Before the COVID pandemic brought the nation to a standstill, Colorado legislators were considering a major new intervention in the state's health insurance and healthcare markets. They proposed a new state-controlled health insurance plan, which would be first offered in the individual market and then expanded into parts of the employer-provided market. Their proposal would have created a Colorado version of the public option, something that Sally did discuss, a concept that's been received significant national attention, but really has never been implemented at the federal or the state level. It's predicted that this public option will return to the state legislature again in 2021, and we certainly want our healthcare providers, our citizens, and our business community to really understand what this concept is about, as well as the financial impact to employers and others, so that you can be a well-informed citizen. And we are so pleased to have with us Chris Brown. He's the Director of Policy and Research at the Common Sense Institute. We're going to have him share information about the study that they've done into the potential impacts of the Colorado Option Plan. Very quickly, a little bit about Chris. He leads the research efforts of CSI to provide insightful, accurate, and actionable information on the implications of public policy issues throughout the state of Colorado. Highlights of Chris's work include modeling the fiscal and economic impacts of Medicaid expansion in 8 states and evaluating the economic impact of major air quality regulation in Washington state. He also helped forecast the state-by-state economic effects of budget sequestration with Third Way, a centrist think tank, and examined a small business tax credit proposal for the U.S. Senate. Since joining CSI, Chris has led several reports on a range of policy and economic issues facing the state of Colorado, including measuring the impacts of a potential 1% growth cap imposed in the state's major metro areas, analyzing the need and options for a PERA reform, simulating the economic impacts of Colorado schools were number 1, and measuring the economic and fiscal impacts of a 2,500-foot setback for new oil and gas drilling. Please welcome Chris Brown.
Fantastic. Thank you so much. I think I unmuted myself. That's step 1 these days in Zoom. Okay, perfect. All right. Yeah, thank you so much. I'm very happy to be here and look forward to questions. And let me share my slides here. Okay. How are we looking? Is that not right? We're good? I get a thumbs up. Okay, fantastic. So thank you again. And yeah, really appreciate the comments and a lot of insightful comments from Sally before me. I'd like to really discuss an issue which has been debated for a little over a year and a half, I guess almost 2 years now here in Colorado, regarding maybe a next step in public policy in healthcare that we've produced now three separate papers on, really looking at this question of a public option and what that looks like and what the implications are, not just in a very limited way, looking at those that it might cover, but I think taking a broader perspective on how this would impact the broader economy and healthcare and employers across the state. Let's see here. I just got a comment saying we're getting the presentation view, not the full slides. If that's the issue for everybody, I think I can change that. Not sure if that's the same for everybody, but just got a note that's saying people can see presentation view. Is that the same for you, Anna, or no? Okay. All right. Well, maybe we'll have to proceed this way then. Okay. Let's see here. Okay. Great. Sorry for a little delay here, but I think people have become accustomed to some minor hiccups in this manner. So CSI, as you discussed, we debate and study and put out research on a wide range of issues and topics, and this has been something at the forefront of our research for some time now. To give you a little bit of background and just to kind of give you a sense of the timeline, this debate really started in earnest following House Bill 1004, signed in 2019, passed in 2019, that started the process of the state evaluating the potential for establishing a public option. And we developed and released several reports prior to the final state report, and then prior to the introduction of the Colorado Option Plan, the legislation that was introduced and then did not move forward earlier this year. But I think the relevant part of the conversation today is that this discussion will likely come back and will likely be at the forefront. Again, I'm thankful I'm not in the business of predictions in today's world, so anything could change. But I do think that the sponsors of the legislation this year have committed to reintroducing and trying to come back with public option legislation likely this year. Before I get into our modeling, I do want to just establish an understanding, maybe in this audience, something you guys are all very familiar with, but just a quick understanding of where the current market is in Colorado, and a key dynamic that exists that I think is really where a lot of the policy efforts as it relates to public option are really trying to train their reform is really targeted to particularly hospitals, and really addressing hospitals and hospital prices and the perceived change in margins. Before we get into that, and I'm not going to dissect that in its entirety today, but I want you to understand that as it exists today, commercial payers, as Sally mentioned, a large share of those that are covered today, a large share of health insurance is covered through public payers, Medicare, Medicaid, but the remaining commercial market pays a much larger share and actually pays well above cost, where a lot of public payers pay below costs for existing coverage. And this is the dynamic as it relates to margin for commercial payers relative to public payers. And the line that you see here is when Colorado expanded and other states expanded Medicaid under the Affordable Care Act, and caused, again, some significant changes to and existing trends only to sort of further divulge. Now, as it relates to cost, one thing, I think it's important to set this up in the sense that the policy efforts have been trained on really reforming prices. And when we get into how the public option is designed, its main mechanism of changing health insurance is to basically pay hospitals a different price and focus on, again, the price that hospitals charge. But for me, and I think it really Sally summed up incredibly well, in a well-functioning market or in developing policy, you really need to understand what are the underlying cost drivers of those prices, and what is causing the higher prices we're all facing, which again, I think is an issue and a worthwhile policy area to focus on. The question is, again, how do you achieve that? Here shows, again, the cost at hospitals per adjusted discharge in Colorado relative to margin, and you can see that the underlying cost of care has gone up 5.5 times more than margin. Okay, so I think it's important to understand this as we think through the implications here of policy. So House Bill 1004, which set the state on this path of developing a policy framework for establishing a public option, had the main goals of lowering premiums, increasing competition, establishing some public-private partnership, and leveraging existing state infrastructure as it was labeled. So what we've gotten, and really what the public option has become is a mandate for insurance carriers to offer a public option plan, a likely mandate for hospitals to accept the public option plan. And again, the option plan, while it would be sold and mandated to be sold by private insurers, would have a rate set by the state through a rate setting formula or some other mechanism, depending on how the policy was formed. So really the question of what's at stake or what are the implications is really a simple dynamic. And it may be a crude analogy, but I think it works in many ways, is if you're familiar with rent control policy in the housing market. Prices are high, but what do we do about it? And if we impose rent control policy that establishes a sort of below existing market rate, what we do is we lower payments to providers. And in the case of the Colorado Option Plan, we lower payments specifically to hospitals, and the policy itself does not change. Competition does not incite any change directly to the underlying cost of care. So we reduce payments, and we in no way directly change the underlying costs that are driving overall prices. So what are our ultimate findings? And I'll leave this up here for a minute, and I will come back to this in my later slides. But by reducing payments and not addressing costs, really what we see as we model this out, and I'll take you through the modeling and some of those results, is really a fundamental trade-off that providers and hospital providers will face as they see a reduction in revenues to either reduce costs, possibly in a way that impacts quality access, or do you pass those costs on through increased prices to the remaining commercial market and sort of exacerbate that cross-subsidization or cost shift that I articulated earlier. So as I said, we've spent a lot of time going through this issue in quite a bit of detail. We contracted with and worked with Guidehouse, Navigant, they're now a Guidehouse company. They're an actuarial firm. We developed an actuarial model that allowed us to simulate introducing the public option plan into the Colorado market, designed in the way that the legislation had written out, and look at the economic impacts through the economic model that we operate here at CSI to determine both the sort of direct impacts and the dynamic impacts. You can find that research on our website on the link below, along with our other papers. The main driver of impacts is what's sort of termed as this migration. You have enrollment migration from existing coverage to the public option plan that's now offered in the individual market. So our scenarios outlined a range of ways in which whether or not the Colorado Option Plan was offered just in the individual market or also the small group market. But we see that while the Colorado Option Plan, the public option would enroll between 130 and 335,000 Coloradans, it would draw from the uninsured market, from the existing individual market, potentially from the small group and even large group, depending upon, again, how the public option was ultimately introduced. The legislation as it was finalized and where it's been left only introduced in the individual market. However, there is a clear indication that the aspirations of the policy would be to expand the offering in the small group market as well. So we modeled that as a scenario. So the direct impact, again, is this change, this direct impact on hospital revenue. And you can see the impacts across our four scenarios in the range of $560 million to $1.2 billion. In light of COVID, we can see that where hospitals are currently, and just some news came out on this the other day that I saw, hospital revenues are expected to be severely hit over this year and next year And while this policy would not be adopted for several years in the future, you can see already the ramifications that these large reductions in revenue are having across healthcare. One important element to sort of pull out of this is the issue related to particularly rural areas and rural communities, rural hospitals that do currently have some of the higher prices. But there, you have to look at the underlying market dynamics. And so while the impacts across the state were in the range of 1.5% to over 3.5%, the impacts on rural hospitals could be up to 6.5%. And so more than the double the impact in urban areas. So again, we're back to the findings here that ultimately say, well, how do hospitals respond? As you face a reduction in revenue, do you cut costs in a way that might impact your workforce, up to 4,800 healthcare workers potentially impacted, or 7% of the workforce? Or do you pass costs on through higher prices? And this shows that pass scenario where if you were to see hospitals shift those revenue reductions to the remaining commercial market, you'd see an increase in the remaining commercial market. Again, this is how we modeled it out. The scenario 4, which again is the introduction of a small group market, we had, and one of our board members offered, who represents and works with the Rocky Mountain Mechanical Contractors Association, a large labor union that represents over 160 different member companies, ran scenario 4 through their own healthcare plan. And in the event they saw the price increases, the cost shift that we've modeled out here, it would add an additional $420 per member for their organization. This is something that we've talked about this. We have some podcast recordings on this topic. We did a webinar in May on this, or March, sort of a blur going back that far, but something that we've been very focused on. And again, there's more resources to help you to understand this if you're interested. But to summarize and sort of leave you with the main areas of impact that we've tried to understand, and through our modeling, we think we have a much stronger sense, and our efforts to try to get this information out and educate, we think can help inform that while you would see lower costs for some consumers in the individual market, again, between 130 and maybe 330,000 Coloradans would enroll, you have a limited impact as described in the state's own actuarial modeling on the uninsured market. So of the maybe 150 to 200,000 Coloradans that remain uninsured, between 9,400 and 1,800 would enroll. And as a result of, again, lowering the price that the public option pays hospitals without changing the underlying cost structure or forcing the change in behavior or competition that, again, Sally articulated, you are left with this decision around cutting costs in a way that might impact, again, access, particularly in rural markets that already face doctor shortages and staff shortages, or do you pass on costs in the form of higher commercial prices? So an issue, again, we will continue to evaluate and be engaged in the coming months. There's a lot going on at the moment, obviously, surrounding public policy, but we think this is a critical issue that people should be aware of and understand the dynamics, again, going into this next session and the next round of healthcare policy debate. So thank you very much. And if there are any questions, I'd be happy to take them.
Thank you so much, Chris. Again, the chat box is live. If you would like to put a question into that live Q&A, we would be happy to pass those on to Chris. Chris, I'm somewhat fascinated by the concepts that were promoted before the public option really gained some traction relative to House Bill 19-1004. any insight there that you could share? I know you're an economist and you're studying kind of the numbers, but any insight there about what happened with that bill and why maybe it fell out of favor compared to the public option?
In 1004, well, so 1004, and I apologize if it wasn't clear, but 1004 established it was essentially a mandate for the state to study the public option. And those were the charges of the state. They had a long listening tour and made trips up to Keystone, myself, to listen to the state as they provided feedback, as they got feedback from different parties as to what the public option would look like. There were a lot of different ideas offered during that process and different ways in which the public option at the time could have been developed, but this is where they landed. Again, maybe in spite of a lot of the other types of ideas that were brought forward, this is where the Division of Insurance and Colorado Department of Health, PHE, excuse me, not CDPHE, but where the HCPUF landed in their final recommendation.
Thank you. Interesting how when you have those side by side, sometimes they do and they don't match up. Something for us to consider as citizens. Were you ever put into a position where, with the modeling you did, you were able to move some levers that actually created something that wasn't as economically damaging for our providers as well as our citizens?
It's a fair question. We did meet with some of the sponsors. We did interact. We ended up doing the modeling really in February, March, and as the pandemic hit, really changed everything. So and then when the legislative session restarted in I think it was May, the legislation had been pulled at that point. So again, we did not participate in any iterations during this last session, but we still have the tools available. We're more than happy to look at alternatives, and I think that is obviously a critical piece to mitigating some of the unintended consequences that we've tried to that we've outlined.
Thank you so much. I think we are incredibly fortunate to have Common Sense Institute in our state and providing those resources, providing that insight, and especially for the insight that you shared today, Chris. We appreciate that. We will be posting a link to CSI's original work on our event website and sharing that out with attendees. So thank you so much. We look forward to